Thank you for your patience, and I'd just like to thank you as an organisation for inviting me here to speak this evening. It's very kind of you. I'm going to give two talks. The first is on first trimester screening, which is very close to my heart, and specifically looking at its role in screening for preeclampsia and fetal growth restriction. I think I should start by saying it's important to recognize that first trimester screening is not dead. So many of you will obviously be using NIPT as a means of screening for aneuploidy, and I just perhaps would make some comments about the value of combined first trimester screening in the context of NIPT. So this is what I think most of us practice at present: combined first trimester screening using a risk algorithm that takes an a priori risk based on maternal age, adds some serum markers and an ultrasound scan to produce a risk for Down syndrome. If you look at the application of this in a population, so this is the whole of the Danish population, then it performs with about 90% sensitivity for Down syndrome and has a less than 5% false positive rate and about a 6% positive predictive value. Now, many of us are considering switching to NIPT because of this paper published by Mary Norton and her colleagues from the United States. And this graph in the blue just shows you the apparent ROC curve for NIPT, which, you know, I've never seen anything published like this as a screening test. And of course, the reality is NIPT doesn't work like this as a screening test. It only looks like this when you omit 3% of the data where you didn't get any results. So this is the Norton study as they published it. It showed a 100% detection rate for Down syndrome, a very, very low false positive rate, and that meant that they had a positive predictive value instead of around the 3% that they had with their first trimester screening of 80%. Now, in this box on the left-hand side, this is the little addendum that you can pick up if you go and read the results section. They didn't report 3% of cases, and there was a whole range of aneuploid cases in that cohort. So in fact, 1 in 38 of the women that they didn't report had an aneuploid pregnancy. Now, in my mind, if your risk is 1 in 38, you actually need to have an amnio for that cohort. So that means your screen positive rate's not 0.1%, it's actually 3.1%. It also means if we include these 3 Downs babies, you didn't pick up 100% of them, you picked up 92% of them. So as a proponent of ultrasound, I would suggest that we haven't actually seen much improvement in screening. This now just shows you on these graphs, if you take into account the 3% that they didn't measure, their detection rate's 92%, not very different to the Danish data, and their their positive predictive value is 7%, not very different to the Danish data. So I think we're at danger of spending a lot of money for NIPT without an improved result in the context of screening for aneuploidy. And there's a whole host of other things that we are now using ultrasound for in the first trimester, which of course NIPT doesn't screen for at all. So in the context of congenital abnormalities, with ultrasound, obviously we pick up some congenital abnormalities, anencephaly, spina bifida, cardiac abnormalities would be an example. There's then issues for preterm labor that I'll come back to later. And then predominantly in this talk, I'm going to talk about screening for the adverse outcomes related to placental insufficiency, so that's preeclampsia and IUGR. So this is a first trimester fetus, and you can see here the typical markers that we would use, the nuchal fluid here, the nasal bone here. In this mid-sagittal section, we also get nice views of the posterior fossa, and with these views, actually, we can rule out spina bifida in the first trimester as well. This is state-of-the-art imaging now in 2016. This is a sneak preview I luckily had of a new product that is a Toshiba product. Again, nasal bone you can see here. You can see the maxilla very nicely, and we now actually can screen for cleft palate in the first trimester because you can actually see a hole in the palate in the first trimester. And again, looking at the posterior fossa, we can see these three components of the brain stem and through to the cisterna magna, which again shows us that there is no spina bifida. So there are other things that we can do in the first trimester as well. This is screening the fetal heart at 12 weeks of gestation. We can see the 4 chambers of the heart in grayscale, but color's great in the first trimester because it allows us to see flow. The red here shows we've got ventricular filling, and then the blue first shows us the outflow, the left outflow tract, and then the little arrow that you can see there is the right outflow tract with the aorta coming back towards it. So at 12 weeks, we can already say that this fetus has a heart that is normally connected. And some of the other new technologies that we can use, this is a technology called SMI, lets us see ventricular filling very readily. We can see that the septum is complete here. We can see venous return, so it's very good for ruling out total anomalous pulmonary venous drainage. And to be able to do that at 12 weeks, I think, is quite amazing. And again, you can see the outflow tracts very clearly and can see them coalesce here in the neck. So continuing on the colour theme, this is now looking at the uterine artery Doppler, and this is one of the main features, if you like, of screening for preeclampsia. And I've just chosen an example here with quite a full bladder so that you can see the cervix beneath it. And the technique that we use for looking at this Doppler in the first trimester is a bit different to later in pregnancy, but this is a very strong marker for preeclampsia, a bit like nuchal is a strong marker for aneuploidy. Other things we like to do in the first trimester, we actually look at the cord. You can see there's hypocoiling here, which is associated with adverse pregnancy outcome, and again is something that we can pick up at an early stage. And then, again, using the SMI technique here, it's useful to identify placental anomalies. So here you can see the filamentous cord insertion that we've got with this posterior placenta, where the cord's then coming round the lateral wall of the uterus and is inserted, say, 3 or 4 centimeters from the main body of the placenta. So turning to preeclampsia. So our problem clinically as obstetricians with preeclampsia is that really we have a conflict of interest for our patients. We all know that preeclampsia is often best served from a maternal perspective by delivery, but of course from a fetal perspective that can be quite disastrous. We've obviously made significant inroads into reducing mortality and morbidity related to preeclampsia and eclampsia. And this is work from a Canadian group that just puts those in some temporal context, first looking at the increased surveillance that we have with things like measurement of blood pressure, then the use of antihypertensives as means of avoiding eclampsia, and then more recently again the introduction of magnesium. And you can see that the overall prevalence of deaths from these diseases has fallen quite dramatically. But women still suffer significant morbidity from preeclampsia. You can see here pregnancy outcomes in relation to rates of induction of labor, cesarean section, things like antepartum hemorrhage, admission to ITU. They're all increased in a preeclamptic population compared to normals. And I think we're now, as obstetricians, beginning to recognize the importance of adverse obstetric outcome in actually predicting maternal morbidity later in life. So here you can see your chance of dying from heart disease or having significant heart disease on the basis of your diagnosis of preeclampsia. And the earlier you have that diagnosis, the more likely it is that you will have cardiovascular disease yourself, ischemic heart disease yourself, and that will be your eventual cause of death. It's not all about the mother, it's also important from a fetal perspective. And if I just draw your attention to one feature here, so this is neonatal encephalopathy and its causes. You see the term cohort makes up about 25% of those. And if you come to birth weight, a low birth weight is by far the most significant factor in terms of your risk of developing cerebral palsy as a child. So the good thing about potentially screening for preeclampsia, rather than just trying to treat this disease once it's developed, is that we potentially have a staged process of disease development, a bit like we see, say, with cervical screening for cervical cancer. And I think there is therefore the potential to intervene at a stage where we can turn the clock back before a disease has truly developed. So this is the concept that in the first stage we have placental dysfunction. That leads to poor implantation, to placental ischemia, the release of angiogenic factors that are designed to improve placentation, but they enter the maternal circulation where they cause endothelial dysfunction and vascular compromise. And then as a result of that, we see the signs and the symptoms and signs of preeclampsia with the end organ damage that we're seeing and the development of hypertension. So in the context of trying to prevent preeclampsia, I'm more interested in this first stage of the disease process to defining the fact that we think there is a risk of placental dysfunction and then trying to improve that situation. So how can we predict preeclampsia? Well, many of us in our clinical practice use this type of process. We take a history of our patients, and that includes factors that we recognize as being high risk or moderate risk. So in the UK, they would score you slightly differently. You'd probably get 2 points for being high risk, 1 point for being moderate risk. In the US, they don't distinguish between the two in the same way. And so each of those factors is weighted equally. And that's really, I think, our first problem in the screening process, is that this currently happens in an ad hoc manner. It depends when our patients attend our practice as to when we take this history. Certainly in my circumstance, if someone interrupts me mid-flow, there's a fairly good chance I might forget one of these important questions. And also, if you say, look at the ACOG list on the right-hand side, you can see that if all of those factors are taken into account, about 65% of your pregnant population will end up being defined as being high risk. So I would advocate that if we are just going to screen on the basis of history, we should at least do it in a slightly more consistent style that firstly weights the individual risk factors properly, and secondly, down the bottom of the left-hand side, you can see if you're parous with no previous preeclampsia, that actually reduces your risk of having preeclampsia in a future pregnancy. And that's a way of actually improving the overall specificity of the test, because here we finally have a risk factor that we're using to reduce risk. Now, in our practice, on the right-hand side, you can see that if we use maternal history alone to compute risks for preeclampsia, then in red, if we just take a history using a scoring system, we would pick up about 35% of cases that deliver before 34 weeks. And if we then do that using a computer, we take that up to about 50%. So even using modern technology in terms of computerization for risk assessment, I think by itself, without any other investigational factors, has some value. In fact, this is the ROC curve for what happens if we take a history in the red line here versus if we use a rather more complicated algorithm that I'm going to talk to you about, which is this blue line here. So I think there is a significant advantage to taking this a step further and to adding other factors. And to do that, we're really following the philosophy that we used for nuchal translucency screening. We're taking maternal history to create an a priori risk. we're then adding biophysical and biochemical markers. So these are PAP-A and PLGF. These are the markers of maternal blood pressure and the uterine artery Doppler. And this was some work of Leona Poon, which she did in London. She's now in Hong Kong. And you can see that using these 4 factors on top of maternal age, she reported a test that had a detection rate of 90% of preeclamptics delivering before 34 weeks. And this test is being done at 12 weeks gestation. So let's just break that down into its component parts. This is measuring blood pressure. Blood pressure is measured in both arms. We use a standardized technique. We use standardized equipment that is checked by medical physics on a regular basis, something that never happened to the Mercury Svig in my clinic for about 25 years, I think. We also then change the data or the structure of the data so that we don't just use pure blood pressure, but we relate it to maternal characteristics like weight. And again, if you just look at our ability on history, we picked up just under 50%, and we add another 20% just by adding mean arterial pressure. You can do the same with the uterine artery. This is why I said it's a very important marker. You can see you add another 30% in terms of the detection rate. And we have a prescribed technique for measurement. So I might just talk about that a little bit more. So you use the probe in the midline, and it's a different technique to the second trimester. You then just change the axis of the probe so that you move to the lateral wall of the cervix, where you can see the vascular plexus like it is here. And then you can put the gated Doppler on, and then you see the waveform of the uterine artery Doppler. Want a nice consistent waveform across several cycles, which we then use to provide a pulsatility index. This is an example here of where you can see some notching in the waveform. Many of us will have grown up recognizing that notching's potentially a problem. That's a second trimester characteristic. In the first trimester, notching is actually quite common, probably affects about 30 to 50% of cases. The other thing I would just show you is that we're measuring the uterine artery here right down at the level of the cervix. It's the cervical branch of the vessel. And the further you move away from this site, then you will get a reduction in the pulsatility index and a reduction in resistance as you work further down the vascular tree. So it's very important that we're localized down to this level of the cervix. And this is just a reminder that the second trimester technique is completely different. So with the second trimester, instead of just rotating the probe so it comes to the lateral wall of the cervix, you really open the probe so that you're really almost over the inguinal ligament, so that you can see the uterine artery. Now, if we're going to start using these types of measures, a bit like nuchal translucency, it's important that we have a quality insurance program in place. So we're actually running one at the moment with our hospital and then 2 private providers in Sydney and in Melbourne. And between us, we look at our mean arterial pressures and make comparisons between different sites. We look at uterine artery Doppler and the biochemistry that we're using. And we're aiming to get these parameters all within these red lines for standardization. We've tested the UK-based algorithm, so that's based on a Caucasian and African population in Sydney, where, yes, we have Caucasians, but probably our other ethnic groups are more Asian rather than African. And we're seeing similar performance. So for a 10% false positive rate, because we don't use PLGF in our practice, we have about a 90% sensitivity with this test. Actually, if you add PLGF as well as another marker, then what happens is you can halve the screen positive rate. And this is what the ROC curve looks like for first trimester screening. You can see it performs much better in predicting early preeclampsia than it does in later forms of the disease. And this is just a demonstration of how the markers vary in a preeclamptic population, represented by the purple lines, compared to controls. Now, this model's in its second iteration now. It uses a rather complex mathematical process that is based around a hypothesis that if women were pregnant forever, up on the top in that dotted line, eventually all of them will get preeclampsia. Now, I think we recognize that women aren't pregnant forever and that they're not all going to get preeclampsia, but this process of modeling then allows you to produce likelihood ratios in the same way as you produce them with the nuchal translucency, with aneuploid screening, that allows you to predict risks. And again, this has been validated, so this is the original data set, and then recently a European consortium, 13 different hospitals in 7 countries, have published this validation paper in, I think, about 10,000 women, showing very similar detection rates. So I think not only do we know that the algorithm is robust in a single population where it's designed, it's one of the few algorithms that we have that has been validated in other population groups. Now, of course, we've all known for a long time that aspirin is an effective way of preventing preeclampsia. So this is the ASCII meta-analysis, sometimes called the Paris meta-analysis, from 2007, and it showed a significant but small reduction in preeclampsia for women who were put on aspirin, a 10% reduction. Now, I can tell you in my personal practice, we don't see many women on aspirin. We see about 3% of women attending at the time of their 12-week scan who are already on aspirin. Bear in mind that according to the ACOG guideline, I should have 65% of my population defined as high risk. So there's a significant difference between what people are practicing and what's, I think, going on in the literature. Interestingly, we know that that dynamic of managing preeclampsia, it's much, much more effective if you start to treat women early. So this is about now not just seeing women at any stage of pregnancy, but making sure if we're going to treat them, we do it before 16 weeks gestation. So after we'd done a validation study, we then did a study where we, in 2 cohorts, compared giving them aspirin if they were high risk to not having aspirin. And we saw a phenomenal reduction in the rates of early onset preeclampsia. Actually, the same as is prescribed in some of the meta-analyses. So this is starting aspirin before 16 weeks. It's giving a dose of 150 milligrams of aspirin at night, and we see a 10-fold reduction in rates of early preeclampsia. We saw no difference in preeclampsia at a later gestation. I can tell you that these data have now been validated by a big randomized controlled trial, which is not yet published, so I can't show you the data because it's not my data, but I can tell you that they have very, very similar effects. So one of the reasons that my clinicians didn't like to give women aspirin was because there was an apparent risk of placental abruption. We have not seen any association with placental abruption in our cohort. And our conclusion is that first trimester screening works, that aspirin does reduce the prevalence of preeclampsia very significantly, and we have a relatively small number needed to treat, equivalent to what we use, let's say, with steroids to prevent things like RDS later in pregnancy. So where are we now? Well, this is data that we updated. So this is, again, the cohort on aspirin, now up to 5,500 patients, still a very low prevalence of disease. And we're interested in trying to reduce rates of IUGR as well with aspirin, because we recognize that from the perspective of stillbirth, IUGR is perhaps one of the most readily areas available to improve outcomes. It's also a target of the World Health Organization, and we've been looking at whether we should use these great charts, the intergrowth charts. I don't know if you've had a conversation about using those locally. Remember, they're based on 35% of the population who are perfect. If you're not perfect, bad luck. Our population is not perfect, so if we plot them on an intergrowth chart, we have fat babies in Sydney. This is quite interesting data because it shows us what we're going to face in the future. We will have more diabetes, more metabolic syndrome, more cardiovascular disease, more gestational diabetes in the girls. This is what we face in the future. And this just puts this in some perspective. So say, for example, in terms of macrosomia, we have about 2 to 3 times as much macrosomia as we should have. So in order for us to be able to look at IUGR in our own population, because our population doesn't fit the international standard chart, we've had to develop our own chart. And we have always felt that at early gestations, IUGR fetuses tend to get delivered because that's what we do as obstetricians. So if we were just to include these in a chart, it would falsely reduce the centiles at the lower gestational age. So we came up with a way of just developing charts based on fetuses that were delivered after spontaneous labour. We looked at a population of 120,000 women. We now have some charts upon which we can define centiles that actually work in our population to see whether we can effectively screen for IUGR. The other little thing that we do is on the left-hand side here, you can see our little space pod that we have on our labour ward. So we actually now measure body fat of all babies at the time of delivery, which would actually be a much better way of looking at IUGR than the current method that we have. So this is the predictive algorithm for IUGR. Again, it comes from the UK. You can see in the UK, they predicted with this algorithm about 70% of early onset IUGR. The rationale, again, would be to give aspirin. This is data showing the reduction in growth restriction if you take aspirin at an early stage. And sadly, it doesn't work in Sydney. So these are the ROC curves for the IUGR algorithm that we've inherited, if you like, from the UK. We haven't published this yet, but we're not seeing the same sensitivity. There is one difference or two differences in our data. The first is that we've already excluded women who had preeclampsia from this data set, and obviously some of the preeclamptics also have IUGR. So we will have dampened our sensitivity by doing that. The second is that we only use PAP-A, not PLGF as they do in London. And I might just skip that and show you, this is actually data from Barcelona, and they actually have a very effective means of screening for IUGR at 12 weeks, and they use both PLGF and SFLIT. So I think we need to go back in Sydney and try it again with another cohort to see if we can improve our performance, and we're about to start using PLGF in our screening algorithm next week. So probably the major downside for this whole screening program is the fact that the treatment is much, much cheaper than the screening test. And so many health economists say, well, why don't you just give aspirin to everybody? Now, I personally don't think that that is necessarily good medicine. I certainly don't think that it's something that we've managed to do effectively with the current ACOG guideline. So I hope that you might support me and agree with me that if we have now produced data that shows we have an effective screening tool at 12 weeks and shows that we can reduce rates of preeclampsia, that that's probably the way to go. A few little things for thought. So this is just if you want to look at the corpus callosum, this is the callosal artery that you can see coming around here, around the front of the brain. First piece of food for thought, up the top here. These are women who were given aspirin for early onset preeclampsia. But you can see actually that we see a significant reduction in IUGR in the cohort who were treated on the basis of a risk for early preeclampsia. So I think there is some value in still trying to predict IUGR in the first trimester and hoping that we can improve that algorithm, because we do seem to have an effective treatment strategy. This is an interesting meta-analysis published earlier this year. They looked at spontaneous preterm birth less than 34 weeks. This is the studies that they looked at. They're all randomized controlled trials. And they showed a 14% reduction in spontaneous preterm birth for women on aspirin. Now, I can tell you, in our own practice, in the last 5 years, our rate of preterm delivery has gone down from 8% to 5.5%. Some of that's because we're not delivering the preeclamptics, but there is something else going on there as well. And I think we need to be interested as obstetricians in the potential impact of aspirin on other adverse outcomes. This is also some work that we've got on aspirin in its effect in preterm pre-labor rupture of membranes. We know that women who are high risk for preeclampsia are actually more likely to have ruptured membranes, and by giving them aspirin, we actually negate that added level of risk. So I'm going to stop there. I'm sorry the lights have gone out on my computer. My computer's set up so that late at night in Australia, it's supposed to give me nice calming yellow light so I go to sleep. So I hope I haven't put you all to sleep, and I'll fix it before we do my other talk. Thank you very much.